Next up, I would like to introduce Dr. Narupon Leungsilapanan to talk about his publication titled Outcomes of supra acetabular pin placement with and without fluoroscopic assisted, a prospective randomized control trial.
Good morning, Chairman and Co-Chairman. It's a great honor for me to be involved in this section. My name is Narupon Leungsilapanan from Maharaj Nakhon Ratchasima Hospital. My research is outcome of supraacetabular pin placement with and without fluoroscopic assist, a positive randomized control trial. As we know that unstable pelvic fracture can be right threatening condition, right? And you should early and rapidly stabilize pelvic to reduce mortality. And anterior flame is not fixator now is the mainstay to treatment, but unfortunately they have two types of the external fixator, but it also have the weak point in each type. For the iliac crest pin also easily to perform but weak in construct. But for supraacetabular pin is stronger construct but have much time to perform. And how to reinforce the stronger one to be less time. According to AO preference, they have proposed the technique that they have percutaneous and open technique that my hospital and my practice have. I try to do the open technique for many times. I found that they quite easily and faster application compared with the percutaneous technique. And because maybe from they can palpate the lighthouse is a AIIS that if you perform with the percutaneous is quite a slope that maybe you can slip the entry point, which they have no any clinical study before, but also have only the catabolic study. That's why it may be my question that to compare the factor is the operating time, accuracy, and complication between these two techniques. For the material method of my researches, design is a randomized control trial. We include the patient with unstable pelvic fracture, but normal hemodynamic is stable and exclude that the iliac crest that cannot put the pin in or any abnormal morphology of the area that we have to insert the pin. And we perform in two techniques in the both sides. We gonna guess that the first side is by the closed envelope, where which technique will be performed first. We use the instrument with the 6mm standard shunt thread pin, which use the sleeve to protect the surrounding soft tissue and put the rod to the pin to connect the construct. This is my technique. The patient on radiolucent table. After we start the surgery, we open the envelope to guess that which one is to go first, mid method. For this case, we use the open technique. First, we open the incision that larger enough to put the finger into palpate the lighthouse. It's a AIS, and then drill at the entry point and follow with the pin and the final check to see that relatively the entry point in the which part of the teardrop. For the another side, we start with OO wheel and then put the drill in and check for the final position of the entry point. And the last thing to do is to connect with the construct. For my consort diagram, we enroll the 20 patients that divide into two sides and 20 hemipelvis per method on the open and the percutaneous technique. Fortunately, I measure only the short-term outcome. That's why we not have the lot follow-up case. For the outcome measurement, we use the operating time as the main outcome and use the accuracy that penetrate out of the corridor or not by using the CT scan post-operative in every case and measure the wound size and the complications such as the pin tag infection. For the demographic data, we use the same patient in each technique. That's why it may be the same demographic data, and mostly of the case is the APC type 2. For the result, surely they have for the timing of the operation, the open technique have a less operative time for about 3 minutes with statistical significantly. For the wound size, it's also bigger than percutaneous technique for about 3 centimeter with statistical significantly. For the result of the complication, they show they have no difference in each technique, but for the interesting point is that the crossing in the open technique, they show that the mapping of the insertion point is quite superior part of the teardrop. That from the research that if superior part of the teardrop is it have a less chance of hip joint penetration. For the kitchen point, for the percutaneous technique, it requires more resource such as fluoroscope that have a more radiographic exposure with spinning out the operative times. But for the open technique, they have no significant inaccuracy, complication with reduced operative time that maybe reduce the blood loss and mortality. That for my research, they have strength with RCT designs. We have post-operative CT in every case. For my developing point, because of they have a fluoroscopic technician, they have a vary in their experience that make some case they have a good time or the bad time. They have no radiographic radiation hazard time to correct, and they use only orthopedic trauma surgeon only to perform the open technique. That's why it maybe cannot generalize to general orthopedists. For my conclusion, the open technique for supraclavicular pin insertion result from my research, they have a rapid assemble, high accuracy, safe and effective for treat pelvic fracture. Thank you.
So thank you very much for a very interesting research.